Dr. Merman, are you back?
Yes, I am.
Right, great. Thanks for joining today too from vacation. Okay. Michelle Sawyer, are you here?
Yes,
Great.
Chair Foster.
Hey, nice to see you. Okay, it's 2:30 and we can resume, and Ms. Sawyer and Mr. McCracken will present the OneCare budget guidance.
Thank you very much, Chair Foster. We are here today to talk about the fiscal year 2024 certified ACO budget guidance and the certification form review. I would like to take a minute to thank the broader ACO team and the HCA for their efforts in preparing the materials for the basis of today's presentation. It really did take a village to get it to where it is today. So the agenda, first we'll cover background and the statutory authority of the board. We will go into the certification eligibility form. We will walk through the budget guidance. We'll talk through next steps and of course have time for public comment and questions. And there is a timeline here. The staff spent May and June working with stakeholders such as the ACO and the HCA, getting the guidance and the certification form feedback. And then today we are presenting on this. Next week, June 28th, there will be a potential vote on the budget guidance. And then we plan on publishing both the certification form and the budget guidance on June 30th. There is a public comment period Susan mentioned. It opened yesterday. We welcome all public comments. You may do so by visiting gmcboard.vermont.gov, and you'll see a button right in the middle of the screen that will lead you through the process. So the ACO budget review, all ACOs operating in Vermont are subject to a budget review. There is a threshold of 10,000 lives, which defines the scope of that review. And we create a guidance, so it's like an annual budget review manual that we give to the ACOs to help that guide the way that they submit their budget to the board. We heard from Julia earlier about the Medicare only ACO guidance, and today we're really talking about the certified ACO budget guidance. The board also goes through the ACO certification process. So ACOs that want to accept payments from Medicaid or commercial insurance must also be certified. ACOs that plan to accept payments from Medicare only are not required to be certified. They just go through the budget process. And for certification, the staff create an annual eligibility verification form. We call it colloquially the certification form. That particular document does not need a board vote, but we will review it today. And then the board's authority is outlined in those two, the statute they're linked, as well as Rule 5. This may be familiar. We have presented on this before. This is just a visual outline that shows really that the guidance process overview depending on the type of ACO that we are considering. So today, if you follow the boxes that are highlighted in yellow, that's what we're talking about today, whereas on the right was the Medicare only ACOs that Julia and Russ walked us through earlier. So the standards and requirements by which we review the ACO submissions are set forth in 18 VSA Chapter 220 and GMCB Rule 5 and in the All-Payer ACO Model Agreement. And I will also note that the ACO does have the burden of justifying its budget to the board. So here's our approach for the fiscal year 24 oversight process. So the process started really with input from multiple internal and external parties. I'll just note that OneCare, as of this meeting, had not provided feedback on the guidance this year, other than some minor technical edits. So the priorities, really the budget targets, as we will discuss, this section of the guidance has been fleshed out considerably this year. We also prioritize the use of the benchmarking report and expect to see the ACO tying their budget to trends we see in this report. The staff aims to complete a data-driven analysis to allow the board to make data-driven decisions. And of course, we look to standardize reports and templates with consistent metrics and definitions. The outcomes of these processes are the reporting manual, which was published at the end of March, and the FY24 budget guidance for Medicare only and the certified ACOs, as well as the certification eligibility verification form. As a reminder, the reporting manual exists to outline the standard reports collected from OneCare during the performance year over year. It includes things like the network development strategy, clinical focus areas, population health and quality improvement reporting, quarterly financial reporting, and then specific reporting on such things like the CPR program and how they're addressing adverse childhood events. There's also a section for ad hoc or one-time reports, as might be requested by a budget order. We aim to also make the budget submission to be about the forthcoming budget year rather than reflecting on the current performance year, because that is really the role of the reporting manual. So here are some staff goals. A lot of the goals from 2023 were carried over into 2024. So I just wanted to outline the ones that we carried over. We started off the process by crosswalking the guidance to Rule 5 to ensure that we were covering all of our bases, that all of the requirements the board must take into consideration were covered by prompts or data collected within the guidance. We do try to emphasize data whenever over narrative explanations whenever possible and where appropriate. We do consider the timing of information requests, such as like sometimes it's really possible for a piece of information to be included with the budget cycle, but depending on the way that the ACO updates certain reports or does planning, sometimes it's more appropriate to collect it at a different time during the year. We're taking into consideration that actually both 23 and 24 are extension years of the APM agreement. We always aim to remove areas identified as duplicative and streamline questions. And we incorporated last year for the first time performance benchmarks and prescriptive guidance as allowed. And as I mentioned, we really fleshed that out this year. So for certification this year, we updated questions based on potential ACO changes. I know that there was a special interest in data analytics, so we fleshed out some of the questions around that. In the budget, we increased focus on performance benchmarks and that prescriptive guidance. We're utilizing the benchmarking report as a source of data for budget analysis. And also included in the budget guidance is an executive compensation analysis that is really new to the budget process. So let's look first at the certification eligibility form. So this is an overview of the certification process for ACOs. As mentioned before, all ACOs that accept payments from Medicaid or commercial insurance must be certified once initially, and then once they're certified, an ACO must annually submit a form to the board to verify that they are continuing to meet the certification requirements to describe any material changes to any matters addressed in the certification sections of Rule 5, which are listed out here. So the 2024 certification materials have undergone changes with the intention of improving clarity and breadth of questions while also reducing burden for both the ACO and staff. The materials are a set of narrative questions and a small Excel workbook that collects data regarding an ACO's policies and procedures. So the material changes, and I'll just make a note throughout this presentation, all of the text in bolded blue indicate changes from last year's guidance. So the first change was the removal of questions regarding the structure of executive compensation. And the logic behind that was that we were going to move this over to the budget process because there's a lot more flexibility in the statute and the way it's written out. So it is not that we are not exploring this area. It is that we simply moved it from certification to the budget guidance. That being said, there are still certain requirements in the certification rule around executive compensation, and we will continue to ensure that OneCare is fulfilling those requirements through the certifying process. We updated software-related questions to better align with the current state of the data analytics structure and to provide more detail in how the requirements of 5.210 are being met. And we modified a question to ensure compliance with 5.206C regarding OneCare's process for monitoring the effectiveness of its population health management policies. So once published, the materials will be posted to the GMC website under the 2024 ACO budget and certification page, and they will be issued to OneCare by July 1st. And OneCare must return the materials to the board on or before September 1st. And just another reminder, the board does not need to vote on the certification form updates. All right, let's get into the budget guidance. So I will just breeze through this slide. We've covered most of this. Just noting OneCare Vermont is currently the only certified ACO in Vermont. So this guidance really has been created with OneCare in mind. All right, so themes for updates this year. Each section was reviewed for clarity, word count, key narrative, highlight of the updates, the submission instructions. We edited those to require formulas to be included within Excel files that were submitted. There were times where we would get information in financial information through an Excel document and not always know where those numbers were tying within other workbooks. So hopefully that will make analyses a little bit more straightforward for our staff. We did remove some of the COVID-19 related language in some of the narrative questions. We targeted questions based on internal review and stakeholder feedback. We focused on benchmarking report results, hospital primary care payments, and executive compensation. We improved upon the data collection templates, and we placed more emphasis on budget targets. So we moved the order of the guidance around so that the budget targets are the very first part of the actual document. After the instructions, these targets are front and center. The objective of these targets is really to provide the ACO with the opportunity to develop their budget based upon the budget targets. So these are priorities that the board has made clear that they would like to see in this budget. There's also in the section the all-payer model growth and financial targets are included. And then we have a set of data and sources that we use when looking at the submission for this section. We reference the Medicare United States per capita fee-for-service projections. We're looking at the March 2023 Medicare benchmarking report. We're looking at Medicare Advantage United States per capita fee-for-service projections, and we reference the HCP LAN report as well. As far as any implications for not meeting a budget target or missing a budget target, there is no hard and set consequence of that. I would say that if the ACO is unable to meet a proposed budget target, that would result in just a very thorough staff analysis. The ACO would have to justify why they were not able to meet this budget target. And it would just undergo a thorough, rigorous analysis at the staff level, and we would, of course, bring that to the board. And if a budget target is to be met, then that would result in a still review, but lesser scrutiny on that particular measure. So here is one budget target that was carried over from fiscal year 23 with no or minor updates. So the first one is that the FY24 commercial benchmark trend rates must be consistent with the ACO attributed population and the Green Mountain Care Board approved rate filings. So new proposed budget targets for fiscal year 24 are the remaining 8. The first is that the ACO shall use best efforts to meet or exceed the goals for reconciled and unreconciled FPP as adopted by the Green Mountain Care Board as seen below, and identify and report specific obstacles to achieving the goals and action steps required by OneCare or others to overcome these obstacles. And the goals for the reconciled and unreconciled FPP for Medicare is 53%, Medicaid 55%, and commercial 24%. The third budget target is the ACO shall hold 100% of the Medicare advanced shared savings dollars at risk at the entity level and not pass this risk along to the provider network. This budget target is a carryover from one of the budget orders from the fiscal year 23 budget, where the ACO was ordered to hold a portion of those shared savings dollars as risk at the entity level. And this is that acted as like a glide path to holding the entirety of this of these dollars. The fourth ACO budget target is to increase risk corridors for all payer programs above fiscal year 23 levels. An increased corridor we didn't want to dictate the amount of that increase because we want to allow for the network to increase the number of dollars at risk and allow for flexibility and negotiation with payers and with the risk-bearing entities. Number 5, the ratio of operating expenses to population health management or payment reform payments, which includes FPP, shall not exceed the 5-year average of 3.25%. And then budget target number 6 reflects a continuation of the trajectory that was set during the vote on June 14th last week regarding executive compensation. The ACO shall cap the total compensation in fiscal year 24 for the ACO's executives, vice president and above at the 50th percentile of the benchmark used by the ACO to establish its executives' compensation. Number 7, the ACO shall structure the variable proportion of executive compensation so that at least 40% is tied to OneCare's fiscal year 24 achievement of specific and measurable goals related to performance and cost and quality metrics. Quality metrics should align with any payer program quality priorities or ACO clinical focus areas, as long as those priorities or focus areas are consistent with the all-payer model quality framework. This has been an area of interest for the board, the general consensus being that the goals that have been set by OneCare historically have been at the ACO operational level rather than at the ACO performance level, and that the board wishes to see at least a portion of variable compensation tied to goals that are more closely tied to the outcomes that affect Vermonters. And we also want to see these goals align with the clinical priorities that the ACO already has in place, so as to support the streamlining of efforts. Number 8, the ratio of population health management funding to the number of attributed lives must be at a minimum of the fiscal year 23 revised budget amount. Specific line items may vary based upon any internal evaluation of the effectiveness of individual population health management programs. OneCare has reported evaluations of some of their internal population health programs, and while we want to see population health investments continue to be a priority for the ACO, we do want to allow for the flexibility should the outcomes of evaluation show that a shift in investments is warranted. And the final ACO budget target, this is regarding the March 2023 Medicare benchmarking report, where OneCare ranks below the 10th percentile among the national ACO cohort, or for metrics where the trend has shown a decrease in performance between the years of 2019 and 2021. Choose 3 metrics that the ACO will address through the Quality Evaluation and Improvement Plan. The ACO should use metrics on which the ACO has the most influence on the outcomes and should justify their choice of said metrics. And then we'll go into part 2. Again, this was previously part 1. There hasn't been a change in the structure of this section other than just moving where it is in the guidance. So section 1 is an ACO budget executive summary. The objective of section 1 is to provide brief narratives to summarize the components of the budget submission and describe the ACO's vision for the coming budget year, including a strategic plan update, the provider network, payer programs, attribution estimates, finances, network programs, and population health and evaluation. There's no specific data or documents for this section because it is an executive summary. So the main change is that the section was revised to capture the shift from the last strategic plan to the new strategic plan that OneCare is putting in place for 24. So question 1, A, B, and C, they were added to capture changes made during the strategic plan that have been in development for 24 and reflections on the previous plan. G and H were added. We added language asking for summary of plans to integrate findings from evaluations and the benchmarking report into their budget and practice. Section 2 covers ACO provider contracts. The objective of this section is to describe ACO network development strategies and any changes to provider agreements and addenda for the budget year. We use appendices 2.1 and 2, which are the network provider lists, and we also reference the provider agreements and addenda that are submitted for 2024. The main change here is that we asked for a description of any changes made to contracts, the provider contracts. But in question 1, we simply removed a table as we found that it was duplicative of another piece of information that we asked OneCare to provide. Question number 2, we asked the ACO to explain changes from the previous year and how each contract aligns provider incentives with the ACO's mission. Question 3, we went a little deeper, asking to the ACO to explain rationale for any changes made to their network development strategy. And then question 4, we updated the table associated with this question to include provider type and ask how the ACO addressed any provider concerns. This question, for context, is around any changes to the provider network if there were provider practices that left the network, just collecting the reasons why they might have left, what kind of provider they were, any response, that sort of thing. Section 3 looks at ACO payer contracts. The objective here is to describe the ACO's expected or assumed payer arrangements used to construct the budget, assess payer arrangements for qualifying as scale target initiatives. We use Appendix 3, which is the scale target initiatives and program alignment forms, and we do reference the payer program agreements once they're executed for 2024. The main change here was that the section was updated with questions regarding changes in public payers and progress with commercial payers. So question 2, we removed a summary table and we added questions regarding the effect of the Medicaid redeterminations, the impact of Medicare Advantage enrollment, and changes as a result of combined. Five. Let's see, pardon me. Question 5, the question was added to inquire about the ACO's efforts to execute risk-bearing commercial payer contracts. Question 6 is a question requesting an update on the FPP pilot with DIVA. OneCare described this pilot as part of their FY23 revised budget, and we're just asking for an update. So section 4 covers total cost of care, the objective being describe the assumptions used to set trend rates and total cost of care targets by payer program and the drivers affecting settlement results of the prior year. We look at Appendix 4.1, which is the total cost of care performance by payer. And we look at Appendix 4.2, which is projected and budgeted trend rates by payer program. So the main change here is that we did remove COVID language from a couple of questions. Question 1, we updated Appendix 4.1 to include both a starting and average attribution by payer program. So we could get a look into what they're expecting for change over the year in attribution. Question 2, we updated to include an explanation of growth rate by year compared to national growth rate by payer. And question 4, the question was updated to assess how the ACO is aligning incentives to meet their growth targets. Section 5 covers ACO network program and risk arrangement policies. The objective is to describe ACO program policies for provider payments and risk arrangements. Describe the ACO risk model by payer and by risk-bearing entity, any ACO held risk, and third-party risk protection. The data sources used in this section are Appendix 5.1, which outlines the risk held by payer and by risk-bearing entity, as well as Appendix 5.2, which covers the shared savings and loss by payer at the HSA level, risk-bearing entity. The main update is we are exploring provider payment strategies that may differ between hospital and non-hospital primary and specialty care practices. We hadn't, in previous iterations of this guidance, gotten down to that level, but for question 1, we wanted to see if there were differences in strategies between hospital and non-hospital practices as far as how providers are being paid. Question 2, the question was expanded to capture the ACO's goals, strategies, opportunities, and limitations on monitoring and providing incentives for reducing potentially avoidable utilization. Question 6, we just reordered this question, and we also inquired about how efforts will improve in fiscal year 24 for identifying high and low value care. Section 6 is the budget section. So the section objective to submit the ACO financial plan prepared according to the full accountability or the non-GAAP and the entity level or GAAP financial sheets. These are submitted through the adaptive database. We also ask for them to submit additional financial data as specified, such as sources and uses, population health management expense breakout, hospital-specific information, FTEs by functional area within the ACO, as well as leadership management salaries. We ask the ACO to describe major variances in the financial plan from the prior year. We ask them to describe outsourced services and fixed operational expenses and describe the basis for the variable executive compensation. So the main change, questions were added to assess specifically outsourced services, fixed operational expenses, and the executive compensation bonuses. So our sources of data here are the full accountability budget, the entity level budget, the variance analysis report, the FTE report, ACO management and compensation, as well as the Form 990, which is generally available in the fall of each year. It doesn't always exactly line up with the budget submission, and as well as their financial audit. So here are some other templates used in this section. The As far as the adaptive templates, we did do some updates to the line items in collaboration with OneCare to ensure that appropriate items are captured. We added some columns in the source and uses template to capture the UVM Health Network self-funded payer program and any hospital fixed payment offsets. For the hospital participation worksheet, we added a row for the UVM Health Network self-funded payer program as well. As far as collecting information in 6.7 for ACO management compensation, we asked for both the current year projected as well as what they were budgeting for the budget year. And as far as 6.8, the population health management expense breakout, we added a row to capture the mental health screening and follow-up initiative in the case that is something that is being budgeted for in 2024. And then also in the adapted database, I apologize, these may have, this is the questions, the narrative questions. We included the staffing sheet, which was not previously collected through adaptive. Sources and uses, just for clarity, we requested definitions for each one of the funding sources. And then question 6, we added this question to explore ACO operational expenses that may be fixed versus variable. We wanted to really get at what operational costs might be affected by increases and decreases in attribution or participation of payers versus fixed costs necessary to do business. As far as question 8 goes, it's a data analytics transition question. We're looking to assess the expected outcomes of the data analytics transition. We wanted to get at what is going to change at the network, at the provider, and at the patient level as a result of this transition. And then we also, for question 12, wanted to expand this question to capture discussion and use of any prior surpluses or losses. Section 7 captures population health information. The objective is to collect data and information on the ACO's approach to population health management and care delivery. We receive the data in the form of 4 different appendices. The ACO clinical focus areas simply compares the status of these areas from previous years to the current year. The population health and payment reform appendix is a convenient way to capture basic information about all of the population health programs delivered by the ACO in one place. Appendix 7.3 provides information about care coordination efforts over the past few program years. And the final appendix provides us with data regarding the amounts paid out to different provider types for each program year with care coordination or more recently, the PHM program. The main update here was to reflect the new care coordination model. There has been a multi-year shift into what we currently know as the PHM, the Population Health Management Model, which incorporates other disparate programs, including the previous care coordination program. So the care coordination program doesn't really exist anymore. It's part of the PHM program. So we had some updates we needed to make. Question 1, we did remove a duplicative question that we covered in section 5 under risk methodology. Question 3, we asked for insight into how they use specific strategies to address root causes and improve results. Question 4, the question is regarding the ACO's methods for prioritizing their investments. And we also updated Appendix 7.2 to include columns for major objectives and outcome measures and KPIs. This was the worksheet that collected kind of all of the different population health programs all in one place. So we're looking to collect any KPIs, measures, objectives that are being collected at the programmatic level. Question 5 is around care coordination. We updated the language to capture assessment of implementation of the PHM program in 2023, any observed clinical outcomes, and any anticipated changes for 2024. We updated Appendix 7.3 to capture the percent of care coordinated population by payer and care managed target for 2024. Question 7 is a new question. We asked for a description of how the ACO ensures that primary care earned incentive dollars are flowing to these providers and or are being invested into primary transformation efforts. This may sound very familiar to our discussion that we had last week. And then question 8 was a new question exploring the consequences or expected consequences to care delivery resulting in the end of the public health emergency. There may be waivers that are being rolled back, and how does the ACO anticipate that changing healthcare in Vermont? Section 8 is around evaluation and performance benchmarking. The objective is to discuss evaluation of provider satisfaction with ACO participation and network programs, and evaluation of the ACO quality improvement program, discuss the use of key performance indicators and the implementation of the ACO performance benchmarking system. There is a new data source, Appendix 8.1, and we also reference the Medicare benchmarking report as submitted in March. So the main change for this section is a continuation of efforts from last year. This section was new last year, and it was a really good starting point, but this year we've really expanded the breadth of questions about how the ACO is evaluating itself and the actions that it is taking as a result of these findings. So question 1 is a new question, and Appendix 8.1 is part of that. So we're looking to collect information about surveys conducted by the ACO and the response taken and the outcome of those responses. And that looks back, over the life of the ACO. And then question 2 gets at what questions the ACO intends to ask its network in the future, and any improvement in their surveying practices. Question 4 is around evaluation of their population health management programs. There are some new sub-questions to this part. We asked about the evaluation outcomes of the CPR and the 2022 care coordination model, as OneCare has shared that they have been doing evaluations on both of those programs. Question 6 is a new question around the ROI analysis that was described during OneCare's fiscal year 23 revised budget hearing. Question 8 is a question that's tying back to budget target number 5, which is the benchmarking metrics. So it's the choosing 3 that the ACO will work on for the performance year. And so we're just we want some narrative to accompany the metrics they're choosing to justify and tying the metrics that they've chosen to the funding streams where they are basically putting money into those efforts. Question 9 is around some causality around some of the metrics that were shown. So there were there were a few different metrics identified by OneCare during their hearing of their revised budget, where they said we have not yet determined the causality of why specialty care visits are low, and why there's high spend in utilization, why length of stay is high, and so I just wanted to follow up with them. We wanted to follow up with them and see if they had been able to dig into causality of those outcomes. So question 10 we would like the ACO to identify specific metrics where they feel they have the most influence on the outcomes, and for those where external factors play a role, how the ACO envisions progress being made in these areas. We're all well aware that healthcare reform is a very complex beast, and it is not, it is very multifactorial, and so being able to parse out where different parties are able to really play a role and be effective in moving the needle on things is something we're trying to get at with this question, at least from the ACO's perspective. And the final section, section 9, covers other Vermont all-payer ACO model questions. The objective here is to describe strategies for assisting the state to achieve the goals in the Vermont all-payer model agreement, describe the ACO's roles in achieving those goals, and to identify opportunities for stakeholder collaboration to achieve these goals. There is an appendix related to this, just collecting information on the quality measures from the all-payer model. And the main change here was very minor. We just removed some COVID-19 language. All right, so the last couple of sections, part 3, is really the revised budget. This just outlines the expectation that the ACO will have to present a revised budget in the spring of 2024. And the only change was to, just a technical update to update it to align with the current revised budget process. And then likewise with the monitoring, this just outlines the expectation that there will be a reporting manual and that there is a current reporting manual that's been published, found at this link. So just technical updates there as well. Just as a reminder, here's the outline of the timeline, just for reference. Encourage any public comment through next Tuesday, prior to the potential vote, which is scheduled for Wednesday. And I will turn it back to you, Chair Foster, for any discussion.
Very much. I'll open up to my fellow board members for any questions or comments they may have.
Was trying not to go first again, so if somebody else would like to go, that's great. Otherwise, I do have a couple.
You're welcome to go, Robin. Go ahead.
Okay, thanks. So I had a couple of questions. The first that is relating to the budget targets. So Michelle, you did an excellent job explaining what happens if targets are met or not met, but I went back and looked and I could have totally missed it, but I don't think that's actually spelled out in the guidance. And I think it might be helpful to spell out what happens if the targets are met or not met in the document itself, which is something that we did do in the hospital budget guidance. So that's just a suggestion for you to think about. No need to respond to that now because I'm springing it on you. So I did have a question about the FPP Medicare goal. In the all-payer model agreement, it is the state's responsibility to negotiate changes to the Medicare program, which, quite frankly, the state has attempted to do in the past unsuccessfully. And so I'm a little curious why we would put a goal around Medicare when it's our collective, not our necessarily Green Mountain Care Board, but the state's responsibility to do that negotiation and make those changes to increase the availability of FPP. So that might be a rhetorical question. If you don't want to answer, that's fine. I think it's a little weird for us to put a target to improve that when we're the ones on the hook for it, we collectively, the state.
I can give a brief explanation of where that target was pulled from, and that was a previous target set by the ACO itself. And so we are just in an attempt to hold some accountability to a target set where we are just encouraging, the ACO to achieve a target they set, and if not possible, to explain any obstacles or barriers that might come between the ACO and their ability to achieve that. So that would give the ACO an opportunity to explain why they might not be hitting that target, and it very well may be the situation that you are explaining, Robin.
Yeah, I mean, my recollection is that the point of that, the board requested the ACO to set those targets at one point, and in that submission, that they made, it was essentially like, we would like to achieve this in Medicare, but state, it's your responsibility to do it. So I don't need to be told that again, personally. I mean, if others would like to do that, then I'm not gonna die on my sword. I think we know the reason why the target has not been met. And it just seems unnecessary to me to include it. So I'll just throw that out there. Thank you for including a question around the impacts of the waivers being rolled back from the sunset of the PHE. I think that'll be interesting and helpful information to understand how some of those waivers will, which made it much easier to coordinate care and do things even outside of the ACO. How that's impacting care delivery, if at all. And maybe, there's been other ways to implement the care delivery changes without those waivers now from Medicare, but I think that'll be interesting to learn about and understand a little better. So hold on, let me just check my list. So the other questions I have are around, and I apologize I didn't ask these last week, but I was not expecting the conversation last week. So how is the 50th percentile benchmark of the executive comp chosen?
So currently, the ACO, through its parent company, if you will, UVM Health Network, they set their executive compensation based on in an internal policy, and that in that policy it is described that the base salary is approximated at the 50th percentile. There is some nuance there. They set a range, and the median of that range for that particular position is set at the 50th percentile. They reference, national kind of comparative groups that they look at, but they also make adjustments in salary depending on the region, and then they kind of give themselves some flexibility there. So the 50th percentile is a little bit of a simplification of the current model of the way that the ACO's executive compensation is currently set. That their base salary is at that 50th percentile, and then with the inclusion of variable pay, it is benchmarked again approximately at the 65th percentile. So to very much simplify it, you're essentially eliminating the variable pay. However, there is nothing in this budget guidance that says that there cannot be variable pay. They would just have to keep that variable pay within the 50th percentile. That you would not be able to go above that, if that is helpful.
Yes, thank you. And certainly I could see how variable pay may vary year to year. With the 50th percentile benchmark, is that a policy that's used at hiring? Like when someone is first hired?
So there is a range. I would imagine it would depend on the individual and experience and all of that. But the pay range of a certain position varies from its median, which is the 50th percentile. There's 50% below and then 50% above at the high range. So I can't speak to how any individual being onboarded as executive for the ACO, where they would fall in that range.
Sure. What I'm trying to figure out is it similar to the state where you're hired into a step in that range encompasses all of the steps that potentially you might accomplish, or whether it is basically the way that it's used to hire somebody into a specific salary and then increases over time would perhaps be set using a different benchmark or a different budgeted amount. I just don't know. So I was just trying to understand that sort of the basics of how this works.
Sure. I did not see that described in the policy we were provided, but it could be that that's included in another more generalized policy that we did not collect. Yeah, so it could be the case, but I did not see it described as such. I would imagine that as national trends changed, the benchmark would then change. So the 50th percentile would change year to year. So salaries would move.
Okay. And do we know how this impacts current employees?
The budget target?
Yes.
Well, it is up to the Board of Managers at OneCare to establish their budget. And it is up to them how they want to either, I don't want to use the word comply because they are not required to comply with any of these budget targets, but they can decide how they want to try to fit that into their budget or not. So I don't have a definitive answer. I'll just want to open it up to Russ too. I see who popped on screen, and he might be able to help with some of these technical questions too. Thank you, Russ.
Sure. I don't have an answer to that exact question offhand, but it's something we can definitely circle back with next week with a clearer response.
Okay, great. I think that is it for me for now. But I'll go off. I'll mute myself and look through my notes to make sure I didn't miss anything. So if someone else has questions, they could go.
Any other board member questions or comments?
I guess I'll pop in here then, since we're on the topic of executive comp. First, a huge thank you to the village, as you described, Michelle, for all the hard work on this ACO guidance. Having watched it over the years, it continues to evolve and improve every year. I think there's some great questions that have been added this year and improved data templates, and really, really thorough. So I'm really appreciative of all the hard work that you and Russ and the rest of the team and village did to get us where we are today. I don't have any questions. I just have a request, actually, for our legal and our ACO oversight teams. The proposed language capping executive total comp at the 50th percentile, it's a fairly new regulatory approach that the board is taking. And I think if we decide to continue in that direction, we should do so with full information about the potential intended and unintended consequences of that sort of regulatory approach. I've always appreciated the board's focus on evidence-based decision making. So I think it would be really helpful if the staff could report back, if we're talking about this next week or before we vote, I guess I would say, if the staff could report back on the pros and cons of imposing total compensation caps for a subset of employees in this ACO guidance, but potentially in future regulatory processes as well. So I guess specifically, I'm looking for a staff analysis of the pros and cons of using executive compensation as a regulatory tool, and also a staff recommendation based on that analysis on whether you think this regulatory approach should be pursued in this ACO guidance. And I think just as a board, I think we should make sure that the benefits that we hope to see by imposing compensation caps outweigh any potential costs or downside implications. I also, and I think, Michelle, to the degree you did answer this to some degree, but it would be really helpful since you're digging into this before next week anyway. I think I'd like to better understand the specific benchmark chosen by the ACO. Is the compensation compared to all healthcare executives in the US? Is it executives at similarly sized ACOs? who are the peer organizations? Is it a national benchmark? You mentioned it might be regionally adjusted. That would be helpful to know. I think if we're going to impose caps on salaries or tying it to a particular benchmark, I think we should understand what that benchmark actually is. So those are just my requests before we head into a vote on this. I think just a deeper understanding of intended and unintended consequences of going into a new lane here, so to speak, for regulatory action.
Any other board member question or comment? I had one, Michelle. I might talk to you about it offline because I want to do some drafting. So I'll wait and get back to you and maybe raise it next week. Any healthcare advocate comment or question?
Thanks, Chair Foster. Thanks to Michelle, Russ, and Jen and others for the great work on this. I think there are a lot of really important updates and edits to the guidance. We largely support it. Just a couple of recommendations for the board to consider. I know we're not voting today. The first one, we would encourage the board to consider revising section 6 to include directors in addition to VPs and above as the category. There are a number of executives that have that title rather than just VP and above. And I think the intent of this approach, if the board decides to adopt it, would be better served if we include those categories as well. And similar to Member Holmes's comment, I think it would be good for the board to consider what peer group to use the benchmark with. Similarly, I don't really know what the benchmark is currently used. It seems like there's a couple different ones. And I think the board would be better served to identify one themselves. And on section 7, we would recommend setting the target to be 100% of variable compensation connected to performance measures that are specific and measurable. We think this aligns with the intent of the rule much better. And we have concerns that the board would be unintentionally lowering that standard by having a percentage that's lower than 100. So those are our comments. Thanks a lot and appreciate the discussion.
Thank you. And sorry, Ms. Sawyer, we don't actually have the benchmarking data that's being discussed, and we don't actually have where the numbers lie in relation to the benchmark data. We don't currently possess that. Is that right?
Correct. We are not in possession of an analysis of really position by position and where each position is benchmarked currently in the percentile. We may have some additional information about the peer group. I have to do a little digging on that, and I will get back to you on that.
Okay. Yeah, it seems like a fair question. I mean, we might as well understand it. I think it's a good point. So if we can put in an ask for that, I think it is logical. I'll turn it to public comment. Mr. Davis, please go ahead.
Thank you, Mr. Chair. I've just got a couple of things to say. I think that I've watched government for 62 years as a professional from one end of the country, including the national level. What you're looking at, what you've just described there is, I've never seen, that's just a bureaucratic nightmare. There's just, if all these hospitals had to actually do that work, it would cost you at least $20 million, and you wouldn't have any idea what to do with it. Government has been working on this for all that time, not in Vermont, I mean, but looking at, well, how does government function? How should it actually work? And an interesting test that I would recommend to you that I know you won't touch is that you should not accept any of the tests suggested unless the bureaucrats can show what they would do if they actually had that information. Just to get it, UVM will be able to do it, but the other hospitals won't even begin to come close to this. Okay, I mean, it just can't be done. Maybe 10%, but if they would actually do it, it would cost at least $20 million extra dollars you'd add to cost. I'd like to just make a comment on your indulgence, Mr. Chair.
Do you mind if I interrupt for 1 minute? I'm sorry to interrupt, but I wasn't clear what topic you were talking about with your first comment about the challenge of being able to get something and what the hospitals would do with it. What topic were you discussing?
The entire laundry list. What I'm talking about is the entire laundry list of question after question after question after question after question. It's not that each question can't be justified, but when you add them all together, there's just simply not enough time to do that. And the only hospital that has a chance to do it is UVM. It's never going to happen in places like Springfield and Rutland. I mean, really is not. That's what I meant. I do have an extra comment on your indulgence, Mr. Chair. One of the things I've been critical here of the board a lot, but I want to say this, that I'm impressed by. I think that one of the things that this board is now really doing is I think they're attacking the issue. I think that they're really starting to get at what it's going to really take to make a system that is sustainable for both cost and quality. I don't think we're close to it there yet, but really trying. I just want to comment that I think that the single most disturbing thing is that the people that really that run 60% of this whole system, 60% of it, are not part of this conversation, and that's their choice. That's UVM's senior management choice, and they are not on. You cannot play in a game unless you're willing to go on the field. And whatever else this board has done, they're on the field. Okay, and whatever else is going on, UVM is not on the field. Thank you.
All right, thank you very much. Sharon, please go ahead. I see your hands raised.
Yeah, I do believe that management of any system and accountability must have compensation relative to the outcomes. And that's where variable pay comes in. I don't know that has been the past, that variable pay has been on actual improvements, because I guess the improvements are not there or questionable. So it is a bit confusing. I would think in the guidelines that I understand the base salary would be 50% of the benchmark. And what I heard was the benchmark is what the ACO presents. So it's not like the board needs to determine what is 50%. That comes from the ACO management or whatever. And then I would hope that the variable pay, but I don't know how it can be legislated, would actually be variable. And I did not hear in the guidelines if the variable pay plus the base would be at 50%, or if variable pay would be, again, based on this peer benchmark. And of course, if everybody is basically getting paid regardless, then it defeats the purpose of variable pay. And then you might as well just go to base salary being 50%. So that's the only thing. The guidelines, there should be some direction of variable pay being paid on outcome. Thanks.
Thank you very much. And Walter, how are you?
Hey, Owen, hanging in there, head throbbing from all the detail here. I do agree with Ham a little bit about the executive compensation, although I think it should definitely be regulated. I also agree with the HCA on it, and I can't, executive compensation is already outlandish. And most of the Vermonters that are paying this in the OneCare make 15, 20, 25 bucks an hour and don't have benefits, don't have health care, don't have retirement pensions or anything like that because they are no longer provided. So the day-to-day Vermonters who are paying these salaries should see some account for what they're going to pay for, what they're paying for, if. So that's a great thing. And Michelle made a comment at the end of her presentation about healthcare reform being complicated. It doesn't have to be complicated. It should be inordinately simple. Every other democratic nation has figured this out. OneCare to me is just another layer of complications. That's it.
Thank you very much. Any other question or comment? Mr. Berman, how are you? Please go ahead.
Hi, this is Abe Berman. I'm the interim CEO of OneCare Vermont. I just wanted to clarify that we did submit a letter on June 9th, and we followed that up with a second letter today. We were not able to comment earlier than that because our board did not meet until yesterday with its regularly scheduled meeting. Further, in reviewing the budget guidance, and I'm a little bit new in the role, having only been here about 3 weeks now. Just, noteworthy that this is a significant body of work that the ACO has to go through each year to provide this information. And unfortunately, that takes away from our ability to work on some of the strategic initiatives that I think the board agrees are really important. So I appreciate all the work that's gone into it, and we certainly will comply to the best of our ability. But I just wanted to be clear that it is a significant body of work, and it is bigger than it is in previous years this year. Thank you.
Thank you very much. Any other question or comment? Okay, great. Ms. Sawyer and Mr. McCracken, thank you very much for your team's diligence and work on this. I think one of you has a day off tomorrow, so enjoy it. I think that's all we have on the agenda today. So is there any old business to come before the board? Or new business? And is there a motion to adjourn?
So moved.
Second.
All those in favor, please say aye.
Aye.
Aye. And we are adjourned. Have a good afternoon.